appointee from south in my neck of the woods, from Burkes Falls, Ontario, Catherine Still, longtime mayor, healthcare advocate, very much involved in the community, and I welcome you.
Thank you.
And if you have any questions and you want to share a ride all the way up here, then let me know.
No worries. Thank you very much.
Anything you would like to add to that?
I was a paramedic for 32 years.
Oh, that's right too. Yes.
I've been on lots of medical boards, and health is my thing, so to speak. So I'm so welcome to come here, and I've got the time now, so I hope I can contribute a little bit. I'm going to learn a lot, I know that. Thank you.
Yes, thank you for joining our team. So without further ado, we'll move to 2.0, the approval of the agenda. Are there any additions to the agenda as presented? No. Hearing none. I'm looking for someone to move that the agenda be for the Finance and Property Committee for September 27, 2023 be approved. So I'm looking for a mover. Rick? Just a second here. Where do I put that? Oh, here. And a seconder? Sarah? Thank you. Be it resolved that the Finance and Property Committee agenda dated September 27, 2023 be approved. Moving to a recorded vote, Rick?
Yes.
Karen Cook?
Yes.
Blair Flowers?
Yes.
Tim Shepard?
Yes.
Sarah Inch?
Yes.
Jamie McGarvey?
Yes.
Jamie Restuel? And myself, yes. Morris?
Yes.
Switzer?
Yes.
And Catherine Still?
Yes.
That motion is carried. Does anyone have a conflict of interest to declare at this time? Hearing none, we'll move on. If you do find that you are in a conflict, please let us know. Moving on to 4.0, approval of the previous minutes for the Finance and Property Committee, June the 28th. So I have a notice of motion, firstly, for the minutes of June the 28th. So I'm looking for a mover. Jamie McGarvey has his hand up. Okay, we'll go with Tim and then Jamie McGarvey. Be it resolved that the minutes from the Finance and Property Committee held on June 28, 2023 be approved as presented. But before that, I should ask if there were any errors or omissions that anyone noted. Hearing none, we'll go to a vote. Rick?
Yes.
Karen Cook? Yes. Blair Flowers?
Yes.
Tim Shepard?
Yes.
Sarah Inch?
Yes.
Jamie McGarvey?
Yes.
Jamie Restuel?
Yes.
Myself. Thank you. Morris Switzer? Sorry.
Those are minutes of a meeting at which I wasn't present.
No, he wasn't here.
Yeah, I know that it's considered okay, but I abstain.
Okay, no, that's fine. Thank you. And Catherine Still.
I abstain.
Okay, so the motion is carried. Moving now to the in-camera minutes of the Finance and Property Committee held on June the 28th. I'm looking for someone to move. Rick? Thank you. And a seconder? Karen. Thank you. Be it resolved that the in-camera minutes from the Finance and Property Committee meeting held on June the 28th, 2023 be approved as presented. Any errors or omissions noted? No. Hearing none, we'll go to a recorded vote. Rick?
Yes.
Karen Cook?
Yes.
Blair Flowers?
Yes.
Tim Shepherd?
Yes.
Sarah Inch?
Yes.
Jamie McGarvey?
Yes.
Jamie Restuel?
Yes.
Myself, yes. Morris Switzer?
Abstain again.
Okay. And Catherine Steele?
Abstain.
The motion is carried. Okay, so, we have it noted that the date of our next meeting is on November the 29th, 2023. Date and, location or time and location to be determined. Business arising, we don't have any at this time. Then we move on to 7.0 new business, and the very first item is 7.1 is the second quarter financial statements, April 1st to June the 30th. And I can only guess that it would be Isabel that would be speaking to this.
Yes, the usual quarterly financial statements are presented for your information. I don't think there's a whole lot that's too exciting here. The very last page, oh, no, we didn't print that part. Okay, no, there's not really anything unusual here, so. There's a few underspent departments. We're still short a few staff here and there, so you'll see that there's a negative variance in a couple of places, but other than that, things were getting a bit more back to normal than you've seen in the last couple of years.
Does anyone have any questions for Isabel? No questions. Wow.
I'll think of some, don't worry.
Oh, I know. I'm counting on that. Okay, so then we move to 7.2, which is the second quarter medical officer of health expenses, April 1st to June the 30th. Isabel?
Yes, they're presented there pretty much with lots of detail for you. So there was a bit of, this is a combined period between Dr. Cherico and Dr. Zimbalati because it was with some of both going on at that point in time. So, but it's mostly Dr. Zimbalati's Alpha conference that is in there.
Anyone have any questions for Isabel? No? No, hearing none. Thank you ever so much, Isabel, for presenting the information for our board. Always grateful that we have someone like you at the helm of the big financial component. So moving on to 7.4, which, no, we move on to 7.3, 2024-2026 funding, strengthening public health.
Okay.
Who would like to speak on that? Dr. Zimbalati?
Yeah, and I can start,
Thank you,
and then Isabel might be adding to what I said. So, you probably did hear about several announcements that were made by the Minister of Health at the Association of Municipalities of Ontario meeting in August. They presented a three-pronged approach to what they call strengthening public health, which involves revising the Ontario Public Health Standards, which are the standards which state our work as a public health unit, as well as encouraging voluntary mergers, and finally to re-examine the funding model for public health. So in the briefing note, It does indicate some of the funding changes that will be taking place 2024 on. And I'll highlight the fact that it means there isn't the same fixed percentage between provincial and municipal contributions that we've been used to using to calculate budgets. And also that the 1% increase that we're anticipating, and we've been told that we're getting for 2024 through 2026, is sub-inflationary. Also, in the strengthening public health plan is the mergers, and this will be something that I do feel as a health unit will need to be engaging in dialogue around with our counterparts in Northeastern Ontario as well as other neighboring health units. I feel that if we don't get ahead of this and start planning the future that we want for ourselves, then this might be decided for us down the road to less advantage. There is significant funding available from the ministry. They tell us to support health units who are committed to merging. These funds extend to supporting wage harmonization, to ensuring continuity of operations, capital expenses potentially. So I think while we do have the chance to explore this on our own terms, it is advantageous that we do so. And Isabel, anything to add?
Yeah, maybe I'll just talk a little bit more about the financial implications at the end of the document. Right now, the province has said that they're going to give us 1% for the 3 years. They can't say what the municipalities are going to contribute. So as long as the municipalities do not decrease their contribution, they're very against that. And essentially, at the time the budget is struck, that funding percentage, whatever the split is at that point in time, will become the split that is used for that calendar year, essentially. So you'll see at the end, I've given you what we think next year's funding will be, and if the 1% is applied to both the municipalities and the province share, then you'll see that next year's mandatory program funding would be around $17,260,000, and that produces a share of provincial 79%, municipal 21%. If we consider as a board that the municipalities need to contribute a little bit more because of inflationary, and we don't want things to decrease as much as they could, then that would change that split a little bit as you go along. This new funding for next year right now is $170,000. And the increase in the payroll by itself is somewhere close to $220,000. So right away, you have a deficit there that has to be met somehow by reductions or whatever. And then on top of that, it's like in your own home, the hydro bill has gone up, the gas bill has gone up, all those things, which we're just in the process of amalgamating to find out what the big hit will be at the end. So the 1% just doesn't go very far, let's say that. The only other thing that Dr. Zimbalati didn't really touch on is right now the messaging is that if if when they change the Ontario Public Health Standards, we're doing less, then we can reallocate those funds wherever we need them at that point in time. But the problem is that all of these things happen at different points of time in this 3-year cycle. So right now, we're setting a budget for 2024. The Ontario Public Health Standards won't be finished being revised till the end of 2024. And then the new funding formula that they're coming out with is not supposed to be ready till the beginning of 2026. So there's kind of lag times in between all these things where we have to manage somehow. So I think that in order to proceed, we're going to end up reducing some positions again in budget because there's not really much other way to make things work. So, but I'm happy to answer any other questions. I know it's quite technical.
Go ahead, Rick.
A couple comments. I'm going to go backwards a little bit. At the AMO conference, the minister spoke. I don't know if anybody else was at the AMO conference or not, but the minister said that the municipalities would not be impacted and we would not lose any money. That was the word that came across. So forward now to the Zoom meeting that we had with the other ministry of the other health units. A lot of those questions came abroad, and that's what came up about entering an agreement with other boards of health. But I explained to him fairly quickly, and Morris was at the meeting also, said north of Barrie, it's totally different than south of Barrie. It's not consistent, and there's no way that we can radiate how we're going to do this. And they said, well, please understand that we're going to work with you, but like Dr. Zimbalati, we got to be ahead of it in order to accomplish something. We may be the hub, we may not be the hub, but at least if we don't get started, we're going to fall behind. And the other question I asked about COVID funding, they said basically COVID funding is going to be done, but if we end up in extra charges or extra funding that needed, they would look at it. Now, that doesn't mean they're going to get it or not, but they said they would look at it. And that kind of bothers me when you say, we will look at it. You can look at it and may not get nothing out of it. But I think you're right, Dr. Zimbalati and Isabel, that we got to be ahead of it and stay proactive instead of deactive. And I know it's not a good thing to hear or talk about, but it's there. But we talked about this before when we amalgamated, when Gravenhurst took over, and we took on 31 municipalities. We were proactive about doing it, and it worked out in our favor. So I would suggest we would look at the same and come back with some kind of a program that'll work for us. Those are my comments. I know Morris was at the meeting too. I think Tim was at the meeting and listened to the same. So again, those are my comments.
No, it pays to be proactive, for sure. Any other further comments? I have one, Isabel, and what could the funding formula look like? What are they?
Anything and everything. The last rendition of it was quite complex. It was based on geography. It was based on, there's something provincially called the deprivation index, it was part of the formula, like what kind of population, whether you have a lot of jobs or you have a lot of people who live by themselves, like all these type of things are taken into account. And it certainly was weighed toward high population areas the last time. It wasn't that popular with the health units because a lot of us ended up getting kind of red circles, and the high population areas ended up with more money. It's hard for the North and the South to agree on these things because often, like, we're so sparsely populated that it's not usually in our favor. But anyway, they're looking at all this stuff all over again. They're starting from scratch. So,
would there be something that could be put forward for all of Northern Ontario, given the differences between the North and the South, the 6 and the 7, as they say?
Yeah, we did that previously. There was a group of us, because we do get the unorganized territories funding. And so the last time there was a separate work group that was just working on that unorganized component. To be honest, we sometimes get into, you know, even trying to agree across the north is not the easiest thing, but I think there's, I think there's opportunities to group together. The northern MOHs meet regularly, so I think we have more power together than separate.
And I will say that the Ministry of Health has outlined that, especially for the review of the Ontario Public Health Standards as well as mergers, there will be consultations with AMO, consultations with Alpha, with others. They haven't quite got to the part of explaining what the consultation process will be for the review of funding, the funding model, but one can imagine that AMO would be consulted on that as well.
Yeah, because that actually was brought up the meeting I was at, that, you know, they're really going back to the beginning in that, you know, about sharing, not sharing, like the whole gamut is going to be looked at. So, which is a bit broader than the previous. The previous was really sharing is definitely in, and then how are we going to share? But this time it seems like they're going further into like fundamentals of how it should be funded. So.
Okay. Do they have a timeline for when all of this will?
Yeah, the funding part of it is a 2025 task, and with the aim that by 2026, I don't know, this is all a long ways off at this point, but 2026 would be the first year of the new funding. I think maybe that's a bit, we'll see.
It is extremely tight timelines for all of these processes. They're looking to leverage our 2024 ASP process, so submissions for that are in March for health units who are kind of confirmed to be proceeding with a merger, not just the consultation process. So very tight timelines on this, and we have yet to hear what the criteria are that they're going to be looking for in terms of merged entities. We're expecting that in the next 4 weeks or so.
Work on that was the end of October, so which doesn't leave much time for this.
Go ahead, Sarah.
So do you see any benefits to the merging? Like, are there any strengths that we can take on from merging with other health units?
So I think with the current funding environment, we are struggling somewhat in terms of a lack of redundancy. We're struggling to have roles and responsibilities completely covered. And I think in future funding environment, that will probably be even more the case, where the funding really won't be appropriate to support small health units.
And can I ask you, is it the staffing that is the difficulty, like that you're finding, or is it resources?
I think a bit of both. Staffing is certainly a consideration. For instance, in our health unit, we have, you know, a staff member or manager covering multiple roles. Potentially, we don't have the same capacity for redundancy that a larger health unit would, where you have multiple people in the same role or covering off different smaller areas. So it does present difficulties for us. So there are some potential advantages. However, if we're thinking that it will save on costs, that's not something we're anticipating. And we do anticipate that the process will be very difficult to work through because at the same time, even if we're able to hire a consultant, which we will need to, there will be extensive consultations within the health unit, which will divert. And as we know, it is hard to recruit staff to the north to work to maybe backfill some of those roles that are being required to spend more attention to the merger process. So there will be growing pains associated with this, certainly. And the end result, I guess, we'll have to
Wait and see.
wait and see. And there are some potential advantages, but would have to see what the final entity will
We always
be.
have to remember that the health unit, like over 85% of our costs are related to staff. So it always comes down to, you know, the number of staff, and that's related to what Dr. Zimbalati says. Like the rest of it is fairly small when you start to make a change in something. It's the staffing that always is the issue, because, or it's not the issue, it's the only way to save money or to.
So would you say that the biggest problem then would be the financing in order, right? The amount of money operating on the budget, and it's not the geography, it's not the delivery of services over a distance?
I would say in the merged entity, that was one statement the ministry did make. They don't expect the general public to see a difference. They expect that, you know, the number of branch offices that people would have might still be the same. The number of people that are working in the community is not going to change. So if you look at it from that point of view, like there's not, and all the health units right now are not resourced the same when it comes to how many like accounting staff they have or how many IT staff they have. So a lot are understaffed already. So it's not as if you're going to gain because suddenly you need one less of this or the other, because most of us are short of those people already. So.
And we would recognize that with a larger geographical area, all of Northern Ontario, all of Northeastern Ontario, we don't face the same challenges necessarily. And so it will be a challenge, I think, with your larger entity to make sure that we're meeting the needs of our diverse population.
So please don't take this the wrong way, anything I say, just to be clear. So when we merge, we will be retaining the ground, like the frontline staff will stay in place. So the services will continue to be delivered ideally, yet the administration would be what would be streamlined. Is that what?
Or reconfigured. And I don't anticipate the merger to significantly impact frontline staff. However, changes to the Ontario Public Health standards and perhaps releveling where some roles and responsibilities lie could mean that some traditional public health roles and responsibilities are then assigned to other organizations, potentially Ontario Health, potentially Public Health Ontario. We don't know what the new OPHS are going to look like, so that would more likely have an impact on who's employing the frontline staff rather than the mergers.
And so who's employing the frontline staff makes a big difference?
We don't know.
Determined.
Yet to be determined, okay.
Okay, Morris, you have a question? Go ahead.
I thank you. I think Dr. Zimbalati just answered it. I understood there was some discussion about other agencies taking on some of the services, so that was going to be my question. And I should say that those of us who were on the virtual meeting with Dr. Moore were a bit startled to hear his economy man, his finance man, say that he assured us there was no economic rationale behind this move, which I just about fell backwards out of my chair when I heard that. But maybe he was having a bad day. I don't know. But but thanks, Dr. Zimbalati. You answered the question.
Are there any other further questions? Yes, go ahead.
Jamie,
Okay, so
Jamie,
sorry.
did she not mention during her, Minister Jones, that they were going to go back from the 70-30, which they had moved us into, to 75-25? And what's the impact then on our budget then if they're picking up more of the cost?
Yeah, so this goes back to that sharing that I talked about a few minutes ago.
Yeah.
In that, so what they ended up doing was going back to 2020, well, sort of. They went back to the funding split at 2020, that the 25-75, but then they proceeded to deviate from that. So I don't know. I mean, it's a bit of a rabbit hole to say that it's anything to do with 75-25 at this point. But what they ended up doing was taking what they gave us last year and adding to that the mitigation funding we've been getting for the last 4 years, and then adding the 1%. And that's next year's funding.
Okay.
But it's all going to be lumped into one number, and it's not being tracked as mitigation anymore. It's all going to be one number. So that's where the sharing ends up being closer to 79-21 than it does to 25-75.
Oh, I understand now. Okay, all right. I wonder, it's a shell game with them. Are they moving more, like there were some programs that were 100% funded. Are they shifting more of those to a split model now?
Well, they were what was being funded with the mitigation money. So now, like, now I guess it's shared 79-21, not 75-25, right? So, we had this conversation, Dr. Zimbalati, myself, and the accountant with the ministry last week, because I said we have to know what this means for returning funds to the municipality. Like, how do we calculate what the percentage is anymore? And so they came up with saying, like, whatever it comes up to be on the service plan when you submit it, that's essentially what you're going to use for that year when you reconcile at the end of the year. They haven't come up with the forms yet, so we'll see how that works out, but that's essentially, so, and it does mean that all over the province, every health unit will have a different share formula because they had different mitigation. Some had no mitigation funding, some had a little bit, like some big health units only had like 400,000, where we had 1.7 million. So it really comes up with all kinds of different sharing formulas.
Thanks.
So that's why it's a temporary measure, essentially, to get us through to when the new formula comes out in 2026.
Okay. All right. Thank you.
Go ahead. Oh, okay. So, well, I'm new to this board, so I'm wondering, you said you'd like to get ahead of this. What do you recommend? Is there a committee that within the health unit that is trying to get ahead of this, that is focused on it? Or is it the roles and responsibility of the board to do this, or?
So the resolution or the recommendation that we're putting forward to Finance and Property is that the board chair, as well as myself, engage in dialogue with the neighboring health units, as well as Northeastern Ontario health units. I think once we get those conversations going, there will have to be some sort of consultation in terms of like to hire a consultant to really examine what that could look like. So it will be something that will be brought back to the Board of Health at I think frequent intervals for updates as to where we are, and before any anything definite was done, it would be the decision of the board to approve or not.
And are there any precedents? Like, has this happened before in Ontario or in Canada with mergers of boards of health?
Certainly.
To look to?
Well, there's been many forced ones and voluntary ones in the last 20 years, let's say that. So there's been two sets of 2 health units that merged voluntarily, And then in our case, we previously were involved in a breakup of one health unit, and it was split between two health units. So Simcoe and us took on pieces of Muskoka Parry Sound back in 2005. So that's the only history that I know in the 20 years. There's been two in Southern Ontario. Elgin St. Thomas and Oxford joined together with another one, which I can't remember at the moment.
When the last one happened, I was chair at that time. Funding was in our favor. We got what we needed to have and more to make it happen.
Yes, it was, there was funding all the way along the process, and I think that the other health units expressed at the meeting I was at 2 weeks ago that, you know, when they had done it at Southwestern, all those components were actually funded for theirs at that point in time too. So the difference between this and modernization, which was talked about pre-COVID, is then people were told, health units were told, you're going to merge with A, B, and C. This time they're kind of allowing us to try and find a better partner that we think fits better. We'll see if we achieve what they want. Hopefully the guidelines are express what they really are trying to get to, because then we'll have some better sense of like how many health units they're looking at the end of the process. Would be nice to know.
But the only thing we can promise is we sit at the table and guarantee we'll have a strong voice. That's all we can guarantee it. So
yeah.
At the end of the day, that's all we can do.
Yeah, and I think there is some acknowledgement from the province in meetings that I've been in that this particular health unit is in a bit of a different place because we kind of sit on the border between north and south. And so, anyway, well,
yeah, that's all.
What that means is who knows, but it's been kind of acknowledged in a couple of meetings we've been in that
Our
that's where we
catchment area is bigger here.
Yeah, and it's,
by us.
yeah, and we don't always fit in either place very well, so it's
And if you could choose the health units that you would merge with, do you have an idea of which ones would be the best fit?
I don't know, Dr.
At this
Cherko has
point?
some, Dr. Zimbalati has some ideas, but I think it's too soon to,
Yeah.
It's preemptive
Yeah.
to say anything.
Yeah.
Okay. So we're still at that stage. We're still investigating which health units.
We haven't engaged in the conversations yet because we're looking for a direction from the Board of Health to do so.
Okay. And that is what's happening this evening?
yeah.
Thank you. Okay.
Are there any further questions from anyone online or anyone in the room? No? So I do have in front of me a recommendation. I will read it first and then ask for a mover and a seconder. Whereas on August the 22nd, 2023, the Minister of Health, Sylvia Jones, presented Strengthening Public Health to the Association of Municipalities Annual Conference, and whereas Strengthening Public Health includes temporary funding for voluntarily merging of health units, changes to the Ontario Public Health Standards after consultation with the field, and the development of a new public health funding formula. Therefore, be it resolved that the Finance and Property Committee recommends that the Board of Health for the North Bay Parry Sound District Health Unit support the board chair and the acting medical officer of health executive director to engage with Northeastern and neighboring counterparts for further exploratory dialogue about voluntary mergers relating to strengthening public health, and furthermore be it resolved that the Finance and Property Committee recommends that the Board of Health supports the participation in all Ministry of Health consultations related to their strengthening public health initiative. Could I please have a mover? And a seconder? Thank you. Blair? Put it to a recorded vote. Rick?
Yes.
Karen,
Yes.
Blair,
Yes.
Tim,
Yes.
Sarah,
Yes.
Jamie McGarvey,
Yes.
Jamie Rastool,
Yes.
Marianne, yes, Morris,
Yes.
and Catherine Still.
Yes.
The motion is carried. Thank you. So now we move to 7.4, which is the reconciled budget for 2023. So I have a motion. I don't know, Elizabeth, would you like to speak to this?
Yeah, I'll try and be brief. The, essentially the funding, the board had originally approved, I don't have it right in front of me, a 2% increase in January, there it is. And, the ministry only approved a 0.7%. It's 7.5%. All their documentation says it's 1%, but it starts April the 1st and goes to December 31st. So it's only 0.75% increase. We have to reduce the budget back to that amount. So, the document, reduces the budget by $205,700. And, we did that. We were kind of anticipating this, so through the year we had reduced a couple of positions. So you'll see that information in the table. We've stopped doing a few things in order to bring the budget into alignment with the funding, and some stuff we had some unfilled positions and so on, so we're able to manage that within this year, and that'll be the starting point for 2024's budget deliberations. So, since these things carry from one year to the next, we did get most of the Ontario Seniors Dental Care Program funding that we asked for. They did prorate it over the end of the year, the different year end. So it's starting in April and ending in March, the increase, but that I kind of anticipated that too, because and we didn't need it for staffing during this year, because the money was to staff the operatories that we're building in Parry Sound, and the people are only moving in right now, and we haven't hired everyone yet. So we're using the money to actually give people care where we can in the community, so more people will get dentures and so on this year with the money, and then next year we'll hire people to work in Parry Sound. So it'll all get spent by the end of the year. I don't know if there's any other questions on this, but we do this on an annual basis, usually in September after the ministry funding comes out. We try and reconcile back to what the original budget.
You just want to speak to then the municipal?
Oh, yes. So there is a municipal component to this, because of course these are shareable dollars. So there is $61,710 that will be going unspent. It can go back to the reserve. That's what I believe I've put into the motion right now. And last year we tried to use it in some of our dental programs, but the capacity right now in the community to do any more work than we're actually doing is not there. So the staff didn't feel that they could spend this money on adult dental between now and December 31st. So I'm just proposing to return it to the reserve.
Any further questions from anyone online or in the room? I'll read the motion first. Or the recommendation, pardon me. Whereas the North Bay Parry Sound District Health Unit received funding for 2023 from the Ministry of Health, and whereas the Board of Health must approve all funding from the ministry in order to receive the transfer payments, and whereas amendments to the previously approved funding affect the total shareable base, therefore be it resolved that the Finance and Property Committee recommends that the Board of Health for the North Bay Parry Sound District Health Unit approve the reconciled 2023 Board of Health budget with the net expenses for $22,423,513. And furthermore, be it resolved that the Finance and Property Committee recommends to the Board of Health that any excess municipal contributions will be put into the municipal reserve. I'm looking for a mover.
Jamie McCarvey is,
Jamie? Thank you, Jamie. And a seconder? Kathy Still, thank you. Moving to a recorded vote. Rick?
yes?
Karen?
Yes.
Blair?
Yes.
Tim?
Yes.
Sarah?
Yes.
Jamie McGarvey?
Yes?
Jamie Restool?
Yes.
Marianne, yes. Morris?
Yes.
And Catherine Still.
Yes.
Motion is carried. Thank you. That gets us moving right along to we have no in-camera, which moves us right along to 9.0, adjournment. Thank you, everyone, for coming out, and I'll move the meeting over to our chair, Rick Champagne.
And if we can take just a few minutes in between.
Okay, we'll take a 1 minute break, couple minute break. Thank you. everybody back. And again, just words again that, congratulations, Catherine, still to be on the board. Put your name forward, and we thank you for being here.
I hope you don't regret it. Just teasing.
I don't think so. You got that voice that just echoes through the hall.
Thank you.
No problem. Approval of the agenda. We need a mover and a seconder, please. Tim Shepherd moves. Second. Off to your left there, Ricky. There she is. Mary Ann Sticklin. All right, we need a recorded vote. Rick Champagne, yes. Karen Cook,
Yes.
Blair Flower,
Yes.
Sarah Inch,
Yes.
Jamie McGarvey,
Yes?
Jamie Restool,
Yes.
Mary Ann Sticklin,
Yes.
Morris,
Yes.
Tim Shepherd,
Yes.
Catherine Still.
Yes.
Thank you. Motion carried. Going to move on to 3.0, conflict of interest, or if you have any, something comes up during a meeting, declare. If not, just let us know. Thank you. Approval of previous minutes. Need a mover and a seconder. Blair? Blair Flower
Jamie McGarvey.
and Jay McGarvey. Where are we here? Let's see. Recorded vote, Rick Champagne, yes. Karen Cook,
Yes.
Blair Flower,
Yes.
Sarah Inch,
Yes.
Jamie McGarvey,
Yes?
Jamie Restool,
Yes.
Mary Ann Sticklin,
Yes.
Morris Switzer,
Yes.
David Wolf, sorry, David's not here, I should have said earlier. Tim Shepherd,
Yes.
Catherine Still.
Yes.
Motion carried. Next on the agenda is 4.2, Board of Health camera and minutes from August 16th, 2023. Has anybody had a chance to look at them? No changes? Not? I got a mover and a seconder, please.
Karen?
Karen Cook, and Jamie Restool. Recorded vote, Rick Champagne, yes. Karen Cook,
Yes.
Blair Flower,
Yes.
Sarah Inch,
Yes.
Jamie McGarvey,
Yes?
Jamie Restool,
Yes.
Mary Ann Sticklin,
Yes.
Morris Switzer,
Yes.
Tim Shepherd,
Yes.
Catherine Still.
Yes.
Motion carried. Next meeting will be November 22nd, 23, time and place to be determined. 6.0, Business Arising, presentation on the Icelandic model. You were speaking on that, Doctor, or?
So I want to introduce Sandy Guindon, who is our manager of Healthy Schools, and she'll be presenting on the Icelandic model.
Thank you. The
Are
word
you
is yours.
able to hear me okay?
Yep.
With it there? Okay, perfect. So I'm the manager with Healthy Schools, and prior to this meeting, in your board package, there was a business case document and a presentation shared. So I will touch on a few of those items, but just at high level because it's a shorter presentation. There is time for questions at the end, and I'm going to probably use my notes so I stay on track and don't wander off for a longer presentation for you. So I'm going to start with a quote from Dr. Tam. This is from the report on the state of the public health in Canada, and highlight that Dr. Tam is calling upon all organizations, including public health, to undertake a coordinated approach to preventing problematic substance use among youth. This is from 2018, but still feels very relevant to our youth today. Touching in on our need and local context, many people use substances recreationally or to cope with stressors, and for some, the use can become problematic. It leads to dependence and other health or social harms. The risk increases the younger substance use starts, and substance use share Substance use and poor mental health are often linked, sharing similar risk and protective factors. At the top here, you'll see in 2017 that the estimated overall cost of substance use in Canada was $46 billion. This is through healthcare, criminal justice, loss of productivity, and other direct costs such as motor vehicle collisions. During the pandemic, substance use was increased among the youth, and this is from our COVID-19 community survey for those youth aged 16 to 24, where 22% recorded an increase in alcohol use, 30% an increase in cannabis use, and 15% an increase in nicotine use. The pandemic was also linked with worsened mental health outcomes for young people, with 1 in 3 individuals reporting the experience of thoughts of suicide or self-harm more often since the start of the pandemic. There is a proposed approach, the Icelandic prevention model, which we have spoke to at this table in the past, and additional details are in the business case. But essentially, the key objective is to implement and sustain an evidence-based, comprehensive approach to reduce substance use among youth in the health unit region. We would like collaboration between our community partners with a shifted social environment to address risk and protective factors, reducing the use significantly. Over the years, Iceland has gained worldwide recognition for the effectiveness of this model. Its global research shows that youth are products of their environment.
Thanks.
This helps to strengthen protective factors and mitigate risk factors, and it lets us know we do not need to explicitly talk about drugs or alcohol to reach the youth. With this, we can have local data. Annual or biannual student surveys would provide us with data on substance use and on the risk and protective factors. We would see survey results in just 8 weeks' time, and we can use that data to inform interventions at a community level. These risk and protective factors reside within these 4 domains. So we would be looking specifically at parent and family, their peer groups, school, and leisure recreation time. This chart looks at alcohol use in the past 30 days over a 16-year time frame when the Icelandic model was in place for Iceland. This compares it to other European countries where they might have been doing something similar to what we've been doing here currently in Canada with trying to reduce substance use, and you can see a drastic difference for Iceland. Due to its success, the Icelandic model has a strong global reputation and has been introduced in 34 countries. As of 2023, it's actively running in 16 countries. Currently in Canada, Calgary, New Brunswick, and several other areas, including Lanark County, Porcupine Health Unit, Temiskaming Health Unit, and Southwestern Health Unit, have signed on with Iceland. There are many other health units also expressing interest through the Public Health Agency of Canada's Community of Practice, including Sudbury and Algoma. It's important to note that the interventions that were implemented in Iceland are not what were implemented in other countries, but rather the process they're partaking in. And the process looks at a 5-year guidance program. So the model is supported over 5 years, where it sets repetition for the communities to set them up for success. It supports data gathering, dissemination, strategy, and action, along with evaluation continued over the 5 years. There's alignment with our work in public health with the Ontario Public Health Standards. So it helps to address program standards among the youth population, specifically in substance use and injury prevention, healthy growth and development, school health, and chronic disease prevention and well-being. And given that substance use and mental health share similar risk and protective factors and outcomes, the local implementation of this model could be structured to support the integration of mental health and the mental health promotion guidelines. One of the principles within the standards is partnership, collaboration, engagement, and these are all the central aspects of this model. We would expect to see locally high quality, timely, localized data, evidence-informed interventions, reduced youth substance use with related harms, cost savings over many agencies and sectors, a broader impact on youth well-being beyond substance use, increased youth resiliency, buffer against adverse childhood experiences, an impact on future generations, an increased collaboration among community partners, and a decreased duplication of services. To implement this model, we need to identify our target communities to move forward. In determining which community or communities within the health unit region would participate, there's several factors to consider, and the first is our partners. So which geographic areas do the involved community partners serve? With equity, we want to look at which communities demonstrate the greatest need based on data. Our geography will have us looking at if multiple communities are participating, are they close enough to collaborate? And readiness. Which communities have the capacity to start and sustain an approach? Have they completed a community safety and well-being plan with youth as their focus? And we've asked ourselves, what if we don't do this? Are we okay with the status quo? Are we okay with the current state for our youth? We know we need to match the scope of the solution to the scope of the problem, and substance use isn't something that just happened overnight, so it will take time to reverse that as well. This cost comes from the Canadian Centre of Substance Use and Addictions from 2020, that every $1 invested in prevention could save up to $22.69 in societal costs related to substance use and harms. Health promotion and health intervention offer significant returns on investment, both in short and long term, and health interventions cost less than treating disease and injuries. Our local progress to date is in February 2023, we held 2 events, one in North Bay and one in Parry Sound, where we invited our community partners and agencies to learn more about this model, and we had 70 agencies sign up to learn. We received signed support from most of our school boards that they will allow the survey to happen in their schools, and the Icelandic prevention model has also been identified as a priority under the Muskoka Nipissing Parry Sound Youth Planning Table. And recently an email was sent out to those who attended the event in February, letting them know we're at a phase to develop a local coalition to identify capacity building needs, funding identification, and community engagement. And 12 of those agencies reached out. They're ready to move forward immediately. To move forward, we will need to secure funds for our coordinator position to oversee the 5-year project, and we will need secured funds to sign an agreement with Planet Youth. Our Healthy Schools team is committed to leading this work, and we will continue to support the youth in engaging them with work associated to the project. Community partners will be asked to contribute to these dollars, and I've broken it down on this slide for you. Our full-time staff salary and benefits are listed, with the Icelandic fee being below, where they will support data collection, analysis, reporting, and capacity building among the local coalitions. Interventions and communities would be extra, and we would look to partners and communities and organizations to help provide those funds. Expenses for interventions will vary based on survey results and interventions selected at the local level. We've also been in contact with the Public Health Agency of Canada, who's investing in this model to support those who are embarking on a 5-year sign-up. We have been meeting with them about our work, and their application for funding opens in October. This source of funding would be a significant support for the project. So the ask of this table, to support the Icelandic prevention model moving forward locally, we're asking the Board of Health to endorse a request to the provincial government to match any funds obtained through Public Health Agency of Canada, and to encourage and support at municipal level for the engagement of our community partners in this initiative.
Well, thank you very much for the presentation. That was quite an eye-opener. Do you have any questions at this moment? Go ahead, Sarah.
Okay, so my question is, I appreciate that the Icelandic model has been tried and tested, but is it possible to simply take the core protocols from this and create our own model, implement it, and save ourselves the cost of the Icelandic model, right?
So we have looked into similar models. they all come with their own costs and with time. And so currently the way we're doing things, our data collection return time frame is 2 years. And so by the time we've collected data from students and we can implement something, we're almost in year 3. And so it's not as effective. And so part of this cost is that 8-week turnaround time with data right to the schools. We currently pay to oversample in our region for data, and we're sitting sometimes at a 40 to 60% rate, and they guarantee 80% rate return.
Okay. And so as far as I understand, the data is collected once every 2 years?
We can ask for it every year, but every 2 years makes probably more sense to allow for intervention time, see what's working, and then collect again.
Okay. I got Morris on, as a question. Go ahead, Morris.
Thanks, through you, Chair. Thanks for that excellent presentation. A couple of things, and then a question. I'm kind of wary of taking models of any kind of social programs from very small populations and trying to transplant them onto larger populations. Iceland has just over 300,000 people. Half of them, I think, were at the World Cup, Men's World Cup, a couple of years ago. I think Finland is cited as a model for prisoner reform, and again, a very small population. I'm not saying they're not doing excellent things. I just am not sure if you can mix apples and oranges. The other thing, there was a lot of talk in your presentation about data collection, and yeah, it's great to identify the occurrence of substance abuse. That's important, but it didn't tell me much about the types of intervention. Can you elaborate on maybe some of the types of intervention that you're talking about, Sandy?
Sure. The types of interventions will be decided at the community level, so I can give examples. We also have the opportunity to have the communities support what the data collection would look like in terms of the questions, so they have a base. But the questions will also ask things about time spent with family, time spent in activities outside of school, participation in school, sleep. So it will go a lot deeper than just the substance use piece, and we'll be able to understand more what students are doing outside of that time. In other communities, there have been implementation of passes for students where every single day they would have an opportunity from when school ended at 3 until parents might be home at 5:30, 6 o'clock to engage in activity free of charge. And communities put that in so that there wasn't students finding alternative things to get into. Some communities put in curfews, and that was something that worked well for them. Other communities have set up opportunities for parents to have classes and courses on how to work with teens. So it can vary, and it really does depend on the community and what issues are brought up.
Thanks. Yeah, thanks, Chair. Just as a comment, I know that Indigenous communities are really plagued with, particularly because of their isolation with these kind of problems. And by far the most success they've had are with programs dealing with cultural context that gives the participants, the youth and adults, a sense of self-worth and belonging, and also experiential learning, being outdoors, which is now becoming a very prominent way of teaching in the public education system. And so we all want to do what's best for our young people during these really challenging times, but I'm just not sure if trying to transplant this model into our communities, is the right answer. That's just my comment. Thanks for the work you're doing.
Great comment. Just one question I have myself is, you're looking at the funding, is it 100% funded by us, or is it going to be a 75-25 split, or is the federal government involved in this in any way possible?
The funding will be split amongst the communities that sign on. We are hoping that Public Health Agency of Canada will be a successful grant with them, and that's where some of our funding will come from, and provincial government would match that or support in kind. Currently, we are having staffing as part of our in-kind piece to lead this model and to do the work.
So I guess my next part of the question is this, if we do decide on looking at this, you're going to bring back a business model before we approve it, yea or nay, that we get the funding in place first before we decide on this. Is this correct?
Business model's been shared with our executive team, and so I imagine that would be brought forward through that team.
Okay. Morris again? Oh, sorry, you hit the button. Go
I just
ahead.
have a quick question. Have you looked at the area in East Perry Sound?
We've looked at our entire district, and when we presented to the Perry Sound area, we did have a lot of interested partners there. So certainly they could still be a community we move forward with. There hasn't been a community selected at this time. It's based on those that are showing interest and feel that they can sustain the model.
Thank you.
Good question, Marianne. Thank you. Anybody else have a question?
So who are these partners that you're referring to? Would that be like councils of municipalities or schools, or?
We are working with all of our school boards. We've reached out to all of our cities and councils when we initially started this project to share the information. We've been working with social sector and recreation sector. Once a community is chosen, we really would need to branch out at that time and make sure every access point that could support a youth would be available.
Does that answer your question, Blair?
Yes.
Okay, thank you. Go ahead, Sarah.
Just a comment, and I want to say that I do appreciate that we do need some upstream programming or interventions to address youth substance abuse. I just wonder if there are any programs that are currently in place at the health unit that could be, maybe that are undersubscribed that we could promote in lieu of signing up for this? So
we do have some current pieces in place. We work with the schools quite extensively in the fall season around vaping and tobacco use in schools, and that includes reduction of that substance or substances. But it's not a community approach. We're not being able to reach the parents in a really facilitated way. We're not able to reach youth on their recreation time. So we're kind of doing a piecemeal because we're just reaching them in one location. And so an approach like this really does wrap around. It ensures everyone's on the same page, and we're approaching all of the topics with the same, the same passion and the same work.
Thank you.
Okay, next one is Jamie Restool.
Thank you, Mr. Chair. Just a quick question, and I don't know if it's too early to get any information or data, but in your slide presentation, you mentioned that there was a couple of fairly local municipalities or towns that were involved in this. Do we have any kind of info on how that's going or how they set up their approach to this?
We know that Porcupine and Temiskaming health units have signed on with the model, and so they are in the preliminary of what those next steps are. Lanark County is probably going into year 2, if not year 3 at this point. They have presented at a Public Health Agency of Canada meeting. They're quite successful in their measures to date with community involvement. And we've also been meeting regularly with Calgary. They are piloting 2 Icelandic models simultaneously, one with their Indigenous communities parallel to one in Calgary, to look at how they can support both communities but with their own models that work for both communities. And then we've been meeting with New Brunswick as an entire province just to see how things are working out for them in a francophone way so that we can use that information as well.
Thank you. I appreciate the response.
Are there any other comments? Thank you very much for bringing your presentation. It was very well done, and we thank you. Okay. Move on to 7.0, the report from Medical Officer of Health.
Yeah, so the report is included in your package, and I would be happy to answer any questions that you had on it.
Thank you so much. Are you waving, Karen?
No?
Oh, I just see your hand going across. I thought you were asking a question.
It's waving to you.
Sorry, I'm just trying to get to the.
No problem.
I see that now. I'm so sorry. I'm
It's all good.
sorry.
See, there is none? Gee, that's good. Oh, Sarah, was that a half a question?
Half a question. Well, I'm just wondering if, I know the report is in front of us, but do you think you could provide a quick synopsis for us of some of the key points?
Well, in the report, I did provide an update on where we anticipate the fall respiratory season going, and that we do anticipate that looking at Southern Hemisphere, that we could see perhaps not as many cases as we have seen in other peak years. However, some severity in terms of the youngest in our population. I also highlighted the actions that we've been taking in terms of fulfilling our recovery priorities, which are our kind of guiding priorities in the absence of a strategic plan currently, as well as outlining what we are envisioning for the strategic planning cycle for our next strategic plan.
Thank you for that.
Any other questions? I don't see anybody else. Thank you very much, Dr. Zimbalati. So I guess we'll go on to 8.0, committee report. I think we have a motion here, right?
2.
Pardon?
I think there's 2.
Is there? You're correct as usual.
Don't mess with her.
All right, for the first resolution, I need a mover and a seconder. Moved by Catherine. Jamie McGarvey. Okay. I'll read the motion if there's any questions at the end. Whereas of August 22nd, 2023, the Minister of Health, Sylvia Jones, presented the Strengthening Public Health and Association of Municipalities at the annual conference, AMO, where the strengthening public health includes temporary funding for voluntary merging of health units, changes to the Ontario Public Health Standard after consultations with the field, and the development of new public and health funding formula. Therefore, it is resolved that the recommendation of the Finance and Property Committee, that the Board of Health of North Bay Parry Sound District Health Unit support the Board of Chair and the Acting Medical Officer of Health, Executive Director to engage with the Northeastern and neighboring counterparts for further exploration, dialogue about the volunteer merger relating to strengthening public health, and furthermore, it is resolved that the Board of Health supports participation of all Ministries of Health consultations related to their strengthening public health initiative. Any discussion? If not, we're gonna ask for a recorded vote. Rick Champagne, yes. Karen Cook,
Yes.
Bear Flower,
Yes.
Sarah Inch,
Yes.
Jamie McGarvey,
Yes.
Jamie Restool,
Yes.
Mary Ann Stickland, Morris Switzer.
Oh, Chair, just before I vote, on my screen, it looks like you're about to fall into a huge glass vat. So please be careful. I vote yes.
Noted. Noted. Tim Shepherd?
Yes.
Catherine Still?
Yes.
Yeah. Motion carried. Second resolution, I need a mover and a seconder, please. Mary Ann Stickland
Jamie Reston.
and Jimmy Restool. Whereas the North Bay as North Bay Parry Sound District Health Unit receives funding for the 2023 from the Ministry of Health Ministry, and whereas the Board of Health must approve all funding from the ministry in order to receive the transfer payment, and whereas amendments of the previously approved funding affected the total share base. Therefore, resolved that the recommendation of Finance and Property Committee, the Board of Health of North Bay Parry Sound District Health Unit approve the reconciled 2023 Board of Health budget with net expense of $22,423 and $22,420. Is that right?
2 million.
22 million. I was going to say, wow, no problem here. You like that, eh? Furthermore, it be resolved that the Board of Health put any excess municipal contribution into a municipal reserve. So I'll have a recorded vote. Rick Champagne, yes. Karen Cook,
Yes.
Bear Flowers,
Yes.
Sarah Inch,
Yes.
Jamie McGarvey,
Yes.
Jamie Restool,
Yes.
Mary Ann Stickland,
Yes.
Morris Switzler,
Yes.
a little glass of water. Tim Shepherd,
Yes.
Catherine Still.
Yes.
All right. I'll carry on to in camera, or correspondence first, sorry. Everybody's had an opportunity to look at the correspondence. It's in your package. We'll move on to 10, in camera, 10.1. So I guess we'll go into camera now. We need a, do we have a mover in a second to go in camera?
Yes.
Okay, we need a mover. Tim Shepherd,
Yeah. Yeah, yeah, yeah.
second. Karen Cook, thank you. Well, now therefore it is resolved that the Board of Health move into camera at 6:20? 6:30?
Yeah.
To discuss agenda, personal matter about identifiable individual. Need a mover? I got a mover. Need a recorded vote. Rick Champagne, yes. Karen Cook,
Yes.
Blair Flowers,
Yes.
Sarah Inch,
Yes.
Jamie McGarvey,
Yes.
Jamie Restool,
Yes.
Mary Ann Stickland, Morris Switzer, Tim
Yes.
Shepherd, Catherine Still.
Yes.
Carried. We're going camera. one here is I just lost my sheet. There we are. Finance commanding camera. New business, item 11-1, intimate partner violence. Dr. Zimbalati, you gonna take the lead?
So we have included a briefing note on this topic within the Board of Health package. And so I would invite board members to comment.
All right, we'll open the floor. Who wants to speak first? I guess I'll start speaking. We're just talking about the issue, it was violence. The only thing that's come to our what we're looking at right now is just the wording of the situation that we're in, pandemic or an epidemic, and that's the wording that we're looking at right now. To have an open discussion, any one incident is too much. That we all agree on. So it's to see how we want to word our motion or how we want to come across, and that's what we're speaking about tonight. So if anybody else wants to have a talk about this, go right ahead, and I'll open the floor.
I'll talk.
Go ahead, Mr. Shepherd.
I think it's a slippery slope if we label this. I, as a police officer for 35 years, 20 of those were frontline duties. I have dealt with hundreds of domestic violence situations from 1980 till 2015. And I've supervised hundreds. And the police training in this province is second to none, all police services. And we have victim services at courts. We have dedicated Crown attorneys who only deal with domestic violence. We have trained police officers that only deal with domestic violence. The paperwork when I started was basically 4 lines in your notebook. The paperwork now, the domestic violence supplementary report, is about 14 pages typed that has to be filled in with every domestic violence call. They're divided into non-criminal code and criminal code. So even now, a shouting match at a neighbor's house between a male and female, a neighbor will call, it's a domestic violence, but you go there and yeah, somebody got agitated and they were yelling. The officers have full rights to go through the house, check everything, talk to them in separately. Anyway, a lot of these are just, they can't be written off in your notebook. They have to be submitted to an expert, another unit. We have so many levels dealing with this. Now, my concern is if we labeled this like a pandemic or epidemic, why aren't we labeling handgun violence? There's way more people killed with handguns in Ontario today, all over. That could be labeled an epidemic. Like we're gonna lessen what that means, I think.
Mm-hmm.
Go ahead, Sarah.
I just wanted to mention that there is still a stigma around intimate partner violence, and it doesn't just happen between men and women. It's, of course, we're in a gender diverse society, and, I think any attention we bring to it helps people feel more comfortable coming forward. And so it's good that this is being talked about this evening.
No, we're not disagreeing that part at all. That's not the issue. I think the issue is just the wording of what's coming across, I believe. And I think what we as a committee got to sit down and get a motion prepared that's appropriate for the health unit, not for individual groups or things like that. And please don't get me wrong, that it's a very important group. It's just that we feel that, or I feel that the wording should be different, and it should be looked at and as a health unit, not as a private group or a personal group. Go ahead, Catherine.
I totally agree, Rick. Where does it end? Where does it start? Where does it end? And you want them out there in the forefront. They are they are the role model and the way things are gonna be with, they have all the information. You don't wanna put them in the back shelf somewhere, but there'll be somebody else coming along too. You don't wanna just, you know, like shallow them away. Like, I think that most people, you know, recognize the fact that any violence of any kind is not right. It's not right at all. Is it an epidemic? No. No, I wouldn't want to be ponied to it, I don't think.
Go ahead, Karen.
I just had a question with regards to declaring an epidemic of any sort. Is that the prerogative of a local public health unit, or is this provincial, federal? How does that work?
So I wouldn't say that there are clearly defined processes or requirements. I just, as a medical officer, acting medical officer of health, and I think as a public health organization, we need to be very careful about the language we use when we are making statements. And, you know, the health unit fully agrees that intimate partner violence is a significant issue and one that requires sustained action. And we are committed to that action. We have been for years. And so I think in the context of a public health organization, we need to be a bit more careful than perhaps other organizations would need to be about using that sort of terminology. So, you know, a municipality that decides that this is the way they want to go, you know, to bring more attention to the issue, by all means, I just think as a health unit, we do need to be very careful.
Thank you.
Go ahead, Jamie McGarvey.
Thank you. Could I make a motion that the health unit explore a motion that would support local action on IPV within the mandate of public health?
I think we can, I believe. Yeah. I will show hands are on the table. Looks like, Dr. Zimbalati, you got your hand up, or is it?
Sorry, I had, let me put it back
okay.
down.
Okay, well, let's, we have a new motion, okay? We'll see what happens. I'll write it in, okay. You don't want to write it? Do you want to rephrase what you just said, Jamie?
That the health unit explore a motion that would support local action on IPV within the mandate of public health. And it could come back to the next meeting.
It's not women against violence, it's something else they call it. They call it the
Intimate partner.
intimate, yeah.
Yeah.
All right, I need a mover. Obviously, Jamie McGarvey, you're going to move it. And I need a seconder. Sarah Inch. That the health unit explore the mandate of public health towards intimate partner violence protocol. Correct? Not protocol?
No.
Okay.
It was to explore a motion that would support local action on IPV within the mandate of public health.
Okay. All right. Moved by Jamie, second by Sarah. Rick Champagne, yes. Karen Cook,
Yes.
Blair Flowers,
Yes.
Sarah Inch,
Yes.
Jamie McGarvey,
Yes.
Jamie Restool,
Yes.
Mary Ann Stickland,
Yes.
Morris Switzer,
Yes.
Tim Shepard,
Yes.
Catherine Still.
Yes.
Motion carried. Now, we can still have some discussion if anyone wants to speak about it, but we'll get a motion prepared for the next meeting, or the motion, we'll have something ready for the next meeting. Is this what I feel?
Yeah.
Or something written up? Okay, thank you very much. Great discussion. And like I said earlier, one violent crime towards that is an issue, but again, we have to watch how the public health comes across. Thank you. 11.2, Proposed Board of Health Governance Framework. That falls under Dr. Zimblati.
Yeah, and I think it's
Jen.
Danielle just joined the meeting online.
There she is. Okay, Dr. Zimblati, go ahead.
So I'll introduce Danielle Hunter to speak to this. Danielle Hunter is our program manager for planning and valuation, among other portfolios.
Thanks, Dr. Zimblati. Hi, everyone. I'm just going to share my screen here. Just make sure everyone can see that. My connection might be a little bit slow. Can you let me know if you can see that?
Yep.
Perfect. So again, my name is Danielle Hunter, Manager of Planning, Evaluation, and Communication Services. I'm happy to be here this evening to provide an overview of a proposed plan to update the Board of Health Governance Documentation Framework. So while I am presenting the content this evening, I would like to note that Isabel Churcher and I have worked on this project together, so we will both be able to speak to this work this evening. I hope that's not on my end.
We're having technical
Microphone off.
Yeah.
There we go.
Is that better?
Yeah.
Okay, thank you. So currently the Board of Health Governance documentation structure consists of 42 different documents. There are 40 governance policies which speak to general topics such as meeting proceedings, organizational planning and brand governance, personnel topics such as occupational health and safety, and staff and volunteer recognition, as well as finance topics such as asset protection and signing authority. There's also a Board of Health orientation manual, which many new board members would have reviewed this past year, which provides education on our health unit and the mandated public health, roles and responsibilities for board members, and some pieces around process such as financial and operational planning cycles. And lastly, there is the Board of Health bylaws document, which specifically addresses board operations such as meeting proceedings and role and conduct of board members.
Danielle, you're muted.
I'm so sorry about that. Did I not unmute from the last? Did you hear the last slide?
Yeah.
Yeah.
Okay, so I just accidentally did that sorry about that. As for the OPHS, the governance policies require updating every 2 years. During the COVID-19 pandemic, there was not capacity to complete this task. However, now with this task back in the forefront, now with this task back in the forefront, an assessment of the current governance structure took place, specifically focusing on the governance policies. So this assessment determined quite a few things. So the governance policies are not currently written according to quality management system standards, such as a policy and a procedure system or framework. On the operational side of the health unit, we are currently undergoing an overhaul of our quality management system, where all quality assurance documents, they're currently called work instructions, are being updated and converted to a proper policy and procedure system. Upon splitting the task of reviewing each governance policy in relation to the other Board of Health documents, a few additional things were noted. So some content of the governance policies are actually outside the scope of the OPHS requirement in terms of what needs to be in a governance policy document. For example, there is a governance policy that states the health unit geographic boundaries. However, this information doesn't necessarily need to exist in a formal policy document, and is already stated in the Board of Health orientation manual. As well, some policies as they're currently written do not include a specific procedure or rule for board members and can be covered in an existing operational policy. For example, the health unit brand governance policy is written as a governance policy. However, the content actually better aligns with an operational communications policy. In addition, many policies only include a one-time task for board members, such as annual review of a report, and the information is actually already covered in existing bylaws. There's also duplication with operational policies. So for example, there is a governance policy and an operational policy that both exist right now related to tobacco, cannabis, and e-cigarette use. Lastly, as mentioned, the governance policies do require updating every 2 years, which requires a lot of time at board meetings, as well as administrative time to complete this task. With this assessment in mind, Isabel and I set out to complete a policy pathway mapping exercise where we reviewed each governance policy in a little bit more detail and answered the following questions. So is there a procedural component to this policy? Is there a specific role for board members? And with that in mind, we identified a new pathway for each governance policy. In other words, does this information already exist or fit within the bylaws document? In this case, we identified duplicate information already found in the bylaws document or sections of the bylaw that could be enhanced to include information from the policy. One example of this would be the policy that outlines appointment, terms of office, and powers and duties for board members, which is already actually covered in section 16 to 21 of the bylaws. Another question we asked is, does this information already exist or fit within the board manual? Again, looking for duplication of information and where information could be enhanced in the manual. Is another document needed? So upon reviewing a few documents, we did note that some content wouldn't fit in either the orientation manual or the bylaws document, but also didn't necessarily need to be a policy document. Lastly, is this information already covered in an existing operational policy or procedure? If so, this policy or procedure could be updated to include board members in the applicability and responsibility section of the policy and then referenced or linked in the board manual for informational purposes. So after the pathway was completed, a new proposed structure was formed. So essentially what we're proposing is eliminating all 40 governance policies. As like I mentioned, the information is either duplicate information already covered in the manual or bylaws, or would fit well in the orientation manual or bylaws in an enhanced format, or it's not required at all as a governance document. In addition, we proposed creating a new code of conduct document that would replace the code of conduct policy, as this content would not necessarily fit in the bylaws or the orientation manual. So this would include a component where the document would be reviewed annually and signed by each board member. These changes would entail a new proposed structure of 3 overarching documents for Board of Health governance. So 1 code of conduct document, an enhanced Board of Health manual, orientation manual, and an enhanced Board of Health bylaws document. Supporting this structure would be the operational policy framework, which identifies all of the operational policies that govern the operational side of the health unit. So these would all be amended to include Board of Health within the applicability and responsibility section of the policy where applicable, and linked and referenced in the Board of Health manual for informational purposes. And just to provide some context in terms of what the operational policy looks like, I provided a list of the policies on the screen. Similar to the governance mapping exercise, an operational mapping exercise actually took place in the last couple of years to identify all of the overarching policies that would cover all of the work of the health unit and our mandated requirements. And so this landed with 17 policies, and this framework is currently in progress. So the framework is to be completed by the end of the year. So you will note that some of them that are marked are either in progress or will be written by the end of this year. As I mentioned, this is part of the health unit's quality management system overhaul, where existing work instructions are currently being updated and converted to a proper policy and procedure format. So in terms of improvements and efficiencies, if we were to move in this direction with the new framework, it would streamline documentation significantly, going from 42 documents to 3 enhanced documents. It would reduce administrative burden. So although the documents would still need to be updated every 2 years, the volume of updating would be significantly less. It would eliminate duplication of information. It would improve board member experience in terms of onboarding and orientation. And it still maintains HPPA and OPHS requirements, as we did obtain a legal opinion in terms of our direction with the proposed framework. In terms of plan next steps, so today we're seeking board input and approval. And should this approval be obtained, an internal working group would be formed to operationalize the new documentation structure. We would aim to have the new draft documents completed by the end of January next year, and then have those documents brought back to a board meeting in February for review, and then implement the final documents by the end of March next year. I'm happy to take any questions that you might have at this time.
Thank you very much. Questions? It was a very put together document. A lot of work was put into that. When you go from a big document to a smaller document, that's always better for sure. Go ahead, Sarah.
Is this something that could be included if, is this something that is being done in other health units?
I could answer that, I guess. Yeah. Every health unit has different ways of doing things. So I would say that it's all over the place. We've asked for other health units, like some health units are embedded in regional municipalities, and so they're doing more things in a municipal kind of fashion. So there's a lot of like bylaw functions, like you would do it at municipality level, and then there's others that have some kind of system. But I think in one way we have one of the new system that we're implementing operation-wise is more clear than a lot of the other health units that I've seen and stuff of. I think from our point of view, when we split it previously, everything was mixed up together. The stuff that affected the board was mixed up in with the operational stuff. So this will make it easier to find. As a board member, I think it will make it easier for you to find what you need to do the job you're here for, rather than trying to find it amongst all the stuff that we as employees need, right? It was kind of all mixed together before.
Well, I think anything that goes from 42 documents to 3 is wonderful. And maybe, if you can share your framework with other health units, that would be great. I don't know if that's a possibility or if there's any way to monetize this, but hey, why not?
And again, thank you, Danielle. Thank you for Isabel for clearing that up. Anybody else have any comments for Danielle or Isabel or Dr. Zambelatti? Good. Okay, thank you very much for the presentation.
Thank you. Thank you. I know.
We'll move on to 11.3, which is the Alpha Symposium registration.
Yeah, so I can speak to this. You would have received an email as a board member, and as well the copy of the email is in the agenda package. There is an Alpha Symposium, which is taking place November 22nd to 24th. And on the agenda, there are some topics such as risk communication, but what we felt as a health unit, we wanted to prioritize the upcoming Board of Health orientation training that we are coordinating to provide with Public Health Sudbury District, as well as Temiskaming Public Health, and feel that managing limited budgets, that, you know, that would be the priority. However, if we did want to have one or two board members attend, the cost, including tax, would be approximately $420. It is a virtual attendance, not in person. We would have to find additional dollars from unexpended to be able to fund that.
Go ahead, Sarah.
Is it possible for one person to attend and record it and share with the others?
Typically, when a Board of Health member attends, it's not necessarily recorded, but they take notes and do report back at an upcoming Board of Health meeting. So usually we do just send one or two representatives that then report back.
What's the timeline did you need to know by?
I believe, is it November 15th?
Looking here, but I don't seem to see it.
November 15th.
November 15th is correct. Closing registration. So if anybody's interested, let us know, then we'll decide it by the next meet. Oh, when's it?
Yeah, so our next
late.
meeting is after that, so that's why I was bringing it forward to this one.
I know I'm not available at that date, so that's all I can tell you. If anybody else is interested, I don't see anybody on the screen.
Sorry,
also.
Dr. Zimbalati, I just, the other proposal that you have for the board members with the other health units, could you explain that a little bit more?
So this is training offered again through Alpha, which is to help orient Board of Health members to their role. I haven't yet seen an outline, like an agenda for the session. It would be a full day session,
Okay.
And with the potential to offer it either in person or virtual. Likely it will be a hybrid event, though in person is encouraged if possible. We have yet to determine the time and place. We hope to have it arranged before the weather would be a significant impediment to travel, would be the goal with that. But Nellie will be coordinating with her counterparts at the two other health units, providing it to make those arrangements.
Okay. So I don't see anybody with their hand up at this time. I know I can't go, so we'll, Sarah, you're gonna put your...
I can possibly go. I can.
Okay. Just let email Nellie and we'll go from there.
So typically, if we are sending someone, then we would have
That's
a
a
Board of
motion.
Health resolution, to indicate that we are supporting the...
Add Sarah's name, okay. Okay, need a mover and a seconder?
Over there.
Oh, there you are. Mary Ann? And a seconder?
Kathy?
Kathy? It be resolved that the Board of Health authorize the following board member to attend the Association of Local Public Health Agencies, ALPHA, 2023 Fall Symposium Select, Section Meeting and Workshop to be held on November 22nd, 24th, and Sarah Inch is going. We'll need a vote. Rick Champagne, yes. Karen Cook,
Yes.
Blair Flowers,
Yes.
Sarah Inch,
Yes.
Jamie McGarvey,
Yes?
Jamie Restool,
Yes.
Marianne Sticklin,
Yes.
Morris Switzer,
Yes.
Tim Shepard.
Yes.
Catherine Still.
Yes.
Before adjournment, new business, I see a couple things I want to maybe talk about. First one is the staff appreciation luncheon. I'm thankful that, I believe Sarah was there, Morris was there, and I believe Tim was there. I couldn't be there. I apologize. I had a real bad cold. I couldn't even talk. So thank you very much for standing up for us. And I believe it was very well received. So again, thank the management staff, and
Jamie Lowry also attended.
Jamie Lawyer was also there? Okay, good. Thank you. And the other one thing I want to talk about, we all seem to have problems with our computers and laptops, and we got issues. Maybe we can have a session where we can rehash this and sit with the IT people and maybe do an hour or two session one day that we can work for all of us, that we can actually sit down and, because everything changes, and I know a lot of us are having a hard time, including myself. And also maybe sitting down and also remembering again to respond to Nellie. She's gonna slap me here shortly, I know she will, but probably one of the worst. But maybe maybe a show of hands, if we all want to sit down and maybe have another session, we can set some dates up and do a straw poll, see who's available and when.
Mm-hmm.
Okay, yeah, I think everybody's on board, yeah. Yeah, everybody on the screen is putting their hands up too, so.
Yeah, no, we definitely recognize there's significant issues here, and I've had discussions with Paul Mascott as well as the IT team that, you know, we do need to figure out a new strategy, some additional training, and if there's ongoing issues, then work to, we need to resolve this.
It's nice to refresh once in a while too, and I know it changes as we go. And I know myself, I got 4 different laptops, and every one of them's different, and or iPads, and it gets a little confusing. And a refresher course, I think, would be great for everybody, especially for the IT team, because I guess they can figure through everything, but we can't.
Did you ask the IT team? They might not. They may say no.
I think they will.
Good.
Again, thank you, everybody, for coming out tonight. I know it was a late meeting, and thank you, everybody, for coming out tonight, and we'll see you at the next meeting. Thank you very much.
Thank you for sharing.
Good night, everybody.
Good night.
Right.